Hello, my name is Jenny Kim, and I am a geriatric nurse practitioner. I am also a professor of nursing at Vanderbilt School of Nursing in Nashville, Tennessee. Today I wanted to talk with you about advanced care planning and really specifically about the role of the nurse. So it is really important for us to understand not only what an advanced care plan is, but the role that we have in making sure that our patients' wishes are acknowledged and honored at the end of life when they're no longer able to articulate those things. So as many of you know, when somebody is admitted to the hospital or admitted to a long-term care facility, we are required to ask them if they have an advanced care plan. Now, all that is required is that we ask if they have one. It is not required to go over one if they do not have one. But hopefully, after listening to this presentation and engaging with your coworkers, you'll feel a little more confident when talking about advanced care plan and perhaps even start some conversations with some of your residents who don't have one. Here are some goals that I have for this session that we have together. The first is that by the end of this session, you will be able to explain what an advanced directive is. The second objective that I have is that you will be able to cite at least one benefit for having an advanced directive in place. And then finally, my objective is for you to be able to explain the difference between an advanced directive and a DNR code status. Oftentimes, these are used interchangeably, but that's incorrect because they're really two different things. Okay, so first off is our question is, what exactly is an advanced directive? Simply put, an advanced directive is a legal document that will specify the medical care that you want in the future if you're unable to express your wishes. So it's essentially a plan for the future, and you are dictating what you would want to have done in different situations. So different states have different forms of advanced directives, but they all include these things right here on the right side of the page. There's a part one in which you can indicate somebody that you want to make your decisions for you. Part two is the actual plan, or it is also called a living will, although that's an antiquated term. But that really digs into exactly what you would want, what your quality of life is that you'd be willing to live with, et cetera, et cetera. And then finally, there's the post, post, or most orders. And that is really for transportation in between different care facilities. And, you know, in the state of Tennessee, we call it a post. However, different states refer to it differently. But essentially, they all have the same goal, and that really is to provide information about an advanced care plan when somebody is transferring to a different location within the healthcare system. Listed for you here on the slide, I have 3 different benefits of advanced care planning. Now, of course, there are more than 3 benefits, but these are 3 benefits that really bubble to the top when I am thinking about ACPs and when I'm discussing it with patients as well. So the first, of course, really obvious is that when your wishes are known, they'll be honored. And there's no way that we know that we can really be confident that we're honoring wishes if these weren't documented. So it's a really, really important document for that in that respect. The second is that family and loved ones, they're not going to feel that burden of making the right decision, making the decision that mom or dad would have made, or making decisions in the heat of the moment, because it's already written out for them. And so they can feel much more confident with the decisions that they're making on behalf of their loved one. And then the final benefit is that it really does provide an opportunity for medical providers to review with the patient and to compare the different care goals with the goals that are really indicated in that advanced care plan. So it's a great communication tool. Okay, so I have an advanced care plan here that I thought we'd go over just bit by bit. As you can see, it's got a lot of information and it can be really intimidating, not only for a patient, but sometimes even for a medical care provider. So first at the top here, you see that you have to put your name. Under the agent, that means somebody that the patient is designating as their decision maker. And you can see you provide the name, the relationship, and then all of the ways in which the healthcare team would be able to contact this person. And that's essential, right? Because sometimes we get into situations where we really need to contact somebody immediately. So the more information you can give here, the better. Now you can see there's also a spot here for an alternate agent, and that's really important because sometimes we can't get a hold of that agent, or perhaps that agent also now has dementia. So much time has passed since his advanced care plan has been written out, and that particular agent maybe no longer has the cognitive capacity to be able to be a surrogate decision maker. So so if people have an alternate agent in addition to the agent, that's great. So, and this is really important right here, this last portion of part 1. When is this effective? So you have two different options. You can make it effective immediately, meaning that I want my agent to make all healthcare decisions for me, even if I have the capacity to do so myself. Either that or the second checkbox, which is I don't give permission for this agent to make healthcare decisions until I lack the capacity to do so. So in my experience, this second checkbox is really much more common because patients fill these out hopefully many years before they would really need them at the end of life, and they want to be able to make their own healthcare decisions. And if you think about it just from a logistic point of view, it really would be difficult if somebody else were making all of your decisions when you're living an independent life and going to your healthcare provider independently. But there is that option. So part 2 really looks at quality of life, and you can read right here, by marking yes, you've indicated you're willing to live with this condition, provided that you have adequate comfort care and pain management. So you can see all of the listed conditions here, and you would check yes or no. So permanent unconsciousness, a permanent confusion, being dependent in all activities of daily living, and then end-stage illness, which often refers to things like renal failure or a metastatic or widespread cancer. So the patient here then goes through all of those different situations. Now, of course, this is a guide. This in no way can really cover every single situation for which we want to measure quality of life. But it's a good guide, and it's a great opportunity for people to be able to indicate how they would define quality of life, or what would be an adequate quality of life for them within these different domains. And then finally, on this first page is your indication for wishes for treatment. And you can see here the 4 different sections. It's CPR, life support, or other artificial support. So things like a breathing machine or a ventilator, or other kinds of medications and equipments that would really help keep somebody alive. There's also the section here, treatment for a new condition. So blood transfusions, treating perhaps some illness that you did not anticipate. And then finally, tube feedings and IV fluids. So that is use of a tube to provide nutrition, or even IV fluids. And you would indicate yes or no. Now, you're probably looking at this and thinking what I'm thinking, and that is that this is really broad. But again, it really helps provide a good, it helps us provide for us great ways to discuss what somebody would want in different situations, and especially when they are no longer able to indicate what those wishes are. On the second page here, you can see there is part 3 where you provide other instructions. And you can be as vague or specific as you would want to. Part 4, of course, is organ donation, and you can see that fleshed out there. Part 5, this is where the patient signs and dates it. And the really important thing here is that in addition to this signature, it needs to be accompanied by either Block A, which includes that you have 2 different witnesses that are witnessing the patient signing the document, or Part B, and that's a case in which you would get it notarized. So you don't need both 2 people, 2 witnesses and a notary. So usually, in my experience, most people, they have the 2 witnesses, and these really if you look at these witnesses cannot be somebody that is the designated agent that was listed on that first page. Somebody that really knows the person well, but is not an agent. And then of course it can't be somebody that would be a beneficiary of their will. So really trying to take out any kind of ulterior motive. So you get that signed with those two signatures. Now, sometimes we do have people that get it notarized, and the situations I've seen that happen, maybe somebody is just private, wants to keep this discussion or this document private, or just really prefers that. But just know it does not need to be notarized. So what do you do when you're done with this advance directive and you have it filled out? Really important to provide a copy to your physician, nurse practitioner, PA. Keep a copy on your own personal files. Tell your relatives that you have one and where it is. And I always tell people to put it in a really accessible location. So I know some people used to keep it in a lockbox in the bank, but if you're the only one that knows the code to the lockbox, or you're the only one that has the key, that's really not the best place to put that document. So someplace safe, but someplace that is easily accessible to others who would need to have this information if you are no longer able to make decisions on your own. Oftentimes people ask me that when does this advanced care become effective? And if you remember the first page of the advanced care plan that I showed you, at the very bottom of that first part, you indicate whether or not you want your power of attorney to make decisions for you, even while you have the capacity to do such, or you indicate that you want that power of attorney to make decisions only when you are no longer able to do such and you don't have the capacity to make these decisions. So make sure that you take a look at that portion of the advanced care plan, because there is some misunderstanding around this. We do have some people that are the power of attorney, but really that hasn't really kicked in yet because their loved one still has the capacity to make decisions. And we really want to make sure that we are giving patients the independence that they so want, and that we need to be also following this advanced care plan as they have directed. So when you think about, well, gosh, what does it mean when they lack capacity? It means that they have usually some kind of a cognitive deficit that's really, it could be either long-term, so dementia, or it could be they're in a state of delirium, or perhaps they're in some kind of unconscious state. So sometimes, of course, you think about people that are undergoing surgery or anesthesia. Obviously, they don't have the capacity to make those decisions while they're in that state. And in this situation, that's when a power of attorney that has been designated would make healthcare decisions for them, really using that ACP as a guide. Let's talk about all this information that we have been discussing and reflect and think how we might see this in a clinical situation. So Mr. Smith has mild dementia, and he was recently in the hospital for a heart failure exacerbation. While he was hospitalized, he was diagnosed with cancer. His daughters are aware of this cancer diagnosis, but they tell you, please don't tell Dad because they are afraid that he's going to get depressed. And they also tell you, well, we know he wouldn't want chemotherapy. So you're taking care of Mr. Smith today, and he asks you, do I have cancer? So I don't know how many of you have been through a situation like this, but like I said, it's very, very realistic. So as a nurse, what do you think your role is here? Do you stay quiet and you pretend that he didn't ask you this question, or what would be your role, and how could you go about navigating this so that he understands that he has a cancer, but that you're also acknowledging the daughter's concern for depression? So I will let you discuss that amongst each other and hit the pause button here. Okay. I would have loved to have heard some of your discussions. When I look at this, I think if I were a bedside nurse, I would actually, of course, I would not tell him that he has cancer because that's not my role, but I would definitely put a call into or talk with the physician, nurse practitioner, PA, whoever the primary care NP is, and let them know that, I think there really needs to be a family meeting because he obviously is anxious and he wants to know if he has cancer, and he has the right to that. But we also want to do it in a way that the daughters don't feel that they're being undermined and that they can really express their concern as well. And of course, they're saying that the daughters are saying he wouldn't want chemotherapy. You'd probably want to look back on any kind of advanced care plan he has to see, did he ever indicate that? So lots to think about here, but you do have a role as an RN, even if you are not facilitating these discussions. These are discussions still that you can be a part of as a member of the healthcare team. I think you all know exactly what this is, a post form. I didn't even have to put the title up here. But you can see at the very top, a copy of this form shall accompany a patient when transferred or discharged. So this is actually very helpful when patients are in an ambulance being transported either back and forth to the hospital, skilled nursing facility, or being transferred to other medical facilities. But again, it's part of this advanced directive, and it really gives an indication of what somebody would want in the situation. They would not be able to answer those questions because they don't have the capacity to do such. So again, I wanted to just point out that if first when you look at this, you think, wow, this is really prescriptive, this is great, but it really does not account for every situation that you might encounter. But you use this information when you encounter those situations, you use this information as a guide when you get into those nuances. I do want to get down to some of the issues that are often included in advanced care planning, and we're going to go over each of these. But these are the most common issues that come up when you're discussing advanced care planning with families. I want to talk first about CPR. I don't know how many of you are fans of Grey's Anatomy. I haven't watched it in years, but I got very sucked into the drama. Obviously, very beautiful people who are doing amazing things. They're cracking chests open and they're saving lives. But it's a really poor portrayal of CPR, what actually happens, because oftentimes they'll bring the person back to life, and then they're up in the bed the next day, eating breakfast, reading the paper, and thanking their wonderful doctor for reviving them. But we know that in reality, that's not the case. CPR is not as effective as we think it is, or as the television or television shows would lead us to believe. I wanted to walk you through this just to show you how ineffective CPR really is. So you look here at this graph, 20 minutes of in-hospital CPR, and that's for all ages. So your 18-year-olds all the way to your 100-year-olds. You see of that group of people, only 44% of patients survive this incident, these 20 minutes of in-hospital CPR. And then when you look at that, 17% of this 44%, they actually survive to discharge from the hospital. And then of that, half of them will go home, and then half of them will return home. And I think it's important to remember that when we talk about returning home, that doesn't mean they're returning back to functional status that they had when they entered the hospital. It simply means that they're returning home. And the other half, it says that the other half do not return home. So that might be that they're going to some long-term facility where they're going to need round-the-clock care, which they could need round-the-clock care as well when they're in the home. I wanted to actually bring some numbers here to this so to help us understand and the reality of CPR and how really ineffective it is. So if we think about, let's say, take a sample of 100 patients. So 100 patients are receiving in-hospital CPR. for 20 minutes. And we know that of those 100 patients, 44 of those patients will actually survive. 58 of them will pass away or expire, but 44 of them will survive. And then of those 44, only 7.48 patients, so not quite 8, but not 7, so 7.5 patients actually will survive to be able to be discharged from the hospital. So that's not a lot of people. And then when you look at those 7.48 patients, 3.74 patients, so not even 4 patients will actually return home, and not even 4 will actually be transferred to a different facility. And that is 3.74 patients of those 100 patients that all received in-hospital CPR. So you can see here, this is really, this is the reality of CPR. And I think it's helpful to share this with patients as well, because oftentimes we don't do a good job of messaging how CPR is really not effective in the older adult population. And again, wanted to emphasize that this includes all adults. So your teenagers, your young mothers, your young fathers, your young men, and your frail older adults. It includes all of these people. And obviously CPR is not as effective for people who are older, as they have more comorbidities. Really important to understand that a DNR is only a DNR. It does not mean anything else. It doesn't mean that we don't treat somebody, that we don't intubate them, that we don't transfer them to the hospital when they need it. It only means that if you see somebody who does not have a heartbeat and they're not breathing, you do not do resuscitation. So oftentimes when people have a DNR code status, they also have other elements of an advanced care plan that also might have some other parameters. So it's really important, if you see that DNR code status, to dig a little deeper looking into their chart to see, are there any other things that they've indicated that they either do want or don't want, and making sure that you understand that. But the absolute most important thing here is understanding that people with the DNR code status, it only means that they are a DNR code status. Many of these patients go back and forth to the hospital. Many of these patients are discharged home. Many of these patients have aggressive care that they're pursuing, but they just don't want to be resuscitated if their heart stops beating. Okay, talking about hydration here, true or false? During the dying process, older adults who stop eating and drinking get thirsty. And the answer to that is false. A lot of times we have families that get very, very concerned for their loved one who's really in that more of an active dying process, that while they haven't had anything to drink, they're really thirsty. I'm afraid that they're not comfortable. But the answer is that this is really the body's natural way of shutting down. And patients who do stop eating and drinking, they do not get thirsty. Some other things about feeding tubes, true or false? Feeding tubes will prevent aspiration in older adults, and that is absolutely false. We do have a lot of patients who do have aspiration events and who have feeding tubes. And then the second question here, true or false? Older adults with dementia will live longer if they have a feeding tube, and that's false. We know from all of the documentation, all the literature, that feeding tubes don't extend life, and they also don't improve the quality of life either. So there are also a lot of other common questions that we encounter when we're talking about advanced care plans. So where can I find one? Go to the Tennessee.gov website. As I had said earlier in this presentation, there are samples that you can download and you can print off, and there's also other information that you can read about advanced care plans, and there are also PowerPoint presentations. You do not need a lawyer to fill out an advanced care plan. You don't need to get it notarized if you have those 2 witnesses that we talked about earlier. So these are all common questions and sometimes myths too. So make sure that now that you understand that you're sharing this with your patients' families as well. Another question here, an advanced care plan may change over time, true or false? And the answer to that, of course, is true. And really, if we are providing care that is congruent with somebody's situation, somebody's deterioration, as oftentimes our older adults, we know that they're going to slowly deteriorate cognitively and physically. And while this process is happening, advanced care plans should also be reviewed regularly. And they really should be in congruence with the health of the individual. I have one more reflection for you that I would love for you to talk amongst yourselves about. So a resident with dementia has an advanced care plan that indicates she does not want a feeding tube. She's lost 10 pounds in the last 6 months and she only eats 25% of her meals. Her family wants to have a feeding tube placed. So I'm sure that you have been in this situation before. So my question to you all is, how can you advocate for the patient's previously stated wishes while also addressing the family's concerns? So this is something where you really can be active in a discussion with family. You might not be leading that discussion. Oftentimes it might be the nurse practitioner or the physician, but you can still really provide valuable information because you know this patient very, very well. And you oftentimes too, you know the families really well. But it's really important as a nurse to be advocating for the patient and what the patient has previously stated as his or her wishes. That is it for the presentation. Thank you so much for hanging in there. If you have any questions at all about the content here, please don't hesitate to contact us. Dr. Kimberly Biting is the director of our Mid-South Project ECHO, and she would love to hear from you. Thanks so much.